Good morning, ladies and gentlemen. This is June 4th, the meeting of the Marion County Budget Committee. We'll call the meeting to order. First item on the agenda is to hear public comment. Staff tells me there is no one here to appear in person. However, Commissioner Carlson, you do have something you want to enter into the record on behalf of a constituent?
Yes, thank you. I received this over email last night, and it is from Marty Hyen. If you may recall, Marty was one of the nominees for the commissioner position, and she has been following our budget deliberations yesterday, and I'm thinking she may be on today. So anyway, this is, I'll just read what she wrote. It says, Juvenile Department Market on Center Street Cash Register. The capital improvements, I believe, portion of the budget document listed a new cash register for $10,000 for the market on Center Street. It was suggested by a person on the board that perhaps something like the Cube should be looked at, since this has a very low cost. Cube is free, but the device it connects to isn't. And you pay as you go, i.e. a % of your sales. I have never used the Cube, but suspect that is a way of accepting money, but is not a true point-of-sale machine and would not do inventory or reporting. If the Cube is a true point of sale, the long-term costs would need to be weighed against the cash register, not just the upfront costs. I would also be more concerned that an iPad or whatever electronic device you are connecting it to could get misplaced, and a cash register is not likely to have this problem. Point-of-sale systems can cost $15,000, so the $10,000 price tag does not sound unreasonable to me. Your information technology department is a great resource to use to determine the best course of action. Sincerely, Marty Hyen. So we'll enter that into the record.
Thank you, Commissioner. And no one else in the room? And I think that's it, staff, and there is nobody that signed in. So without objection, we will recess to reconvene for the regular budget meeting at 9 o'clock. We will be in recess. Good morning, ladies and gentlemen. This is the Marion County Budget Committee meeting for June 4th. We will reconvene. First item on the agenda is Health Department. Dr. Calkins, good morning.
Good morning.
Identify yourself yourself and your companion for the record, please.
I'm Rod Calkins. I'm the administrator at the Marion County Health Department, and with me this morning.
And I'm Ryan Matthews, Senior Administrative Services Manager for the Health Department.
Thank you.
We're going to be presenting the Health Department budget today, which begins on page 458 of your budget book. But before we begin, I want to comment that I look a lot better, I think, than my usual slide that Hitesh puts up there. So I at least have changed from my gender changed from last year to a classic building, which we'll talk a little bit about later on. Anyhow, the Health Department budget includes funding for services with individuals with developmental disabilities, mental health, and substance abuse issues, as well as public health services. The total budget is over $74 million, of which, for reference, about $3.44 million comes from county general fund. The remainder of the budget is a combination of state, federal funding, block grant funding, some grants, and a lot of reimbursement for Medicaid services. So one of the takeaways is that most of what we do at health is externally funded, and much of it is from revenues obtained for the services that we deliver. We employ about 390 FTE. Last year we served over 49,000 people with over 426,000 client contacts, so a lot of interaction with the community. Despite some dark clouds on the horizon in last year's budget presentation, the Health Department has actually grown this past year. And this has been particularly due to a series of community mental health reinvestments that were made at the close of last year and are starting to take effect now. These were made by the Oregon Health Authority as part of their agreement with the U.S. Department of Justice to invest more in the community mental health system. What I want to do today is talk about a couple of the large issues that are facing the health department, and you have a handout that goes with this presentation that I hope will be helpful in illustrating some of those large-scale changes and difficulties that we anticipate. First thing I wanted to talk about a bit is our developmental disabilities program, and in your budget book that begins on page 465. It's actually our second program area. And also, if you want to accompany it with this page in the handout, I think it's labeled page 3 of your handout, that has a single pie chart in the middle, I think that will be helpful as well. That handout page is titled Marion County Health Department Community Developmental Disabilities Program Funding Changes. What we are facing this year and what we are participating with the state and other counties in is a number of major changes to the system. Two, really. One to the funding model and the other to the way in which we do our work. There's not a whole lot else to change besides those. So the whole system is up in the air to some extent, and it's taking a lot of work on people's time in addition to the services that they regularly provide. Until the late 1990s, there actually was a state institution here in Salem for individuals with intellectual and developmental disabilities called Fairview, which closed in the late 90s as part of a movement to have people move back into the community, and probably as a result of a lawsuit that said that you needed to serve people in the least restrictive environment that was appropriate for their needs. Many of the individuals who worked at Fairview lived in this community, and when Fairview closed, they established foster homes here in the community. So Marion County actually has a large number of individuals with intellectual and developmental disabilities, relatively larger than what might be expected for a community our size. Okay, the two major changes I talked about are what's being called a change to a new Medicaid waiver called the K plan. And this requires a more detailed assessment of the individual who's going to be receiving services to establish their eligibility for services and what services exactly that individual might need, that individual and their family might need for them to be successful. So typically we talk about this as a system that is more person-centered rather than program-centric. Second change we're moving to is the system is moving from the caseload model to what's called a workload model. The caseload model is a payment system by which you're paid by the number of people that you have enrolled in your developmental disability program on your caseload. As long as clients have pretty much the same mix or similarity of needs, caseload model is not a bad proxy for the work it actually takes to provide services to the individuals who need it. But the needs of our clients and families really vary greatly, from things that are relatively minor, straightforward, periodic checkups, to things that take intensive work for days at a time. So what we're looking to do with the workload model is move to a model that reflects the actual work that needs to be done and reimburses appropriately for that work. We're hoping that this leads to a more fair system of reimbursement across the counties. And what we're expecting is that we will see some increase in funding to move the level of funding to what it actually costs to do the work in the community. That's been the experience as the aging services system moved from a caseload to a workload model, and we're expecting that that will be a similar experience with our developmental disability program. This is a tremendous amount of work in the system that's already overburdened. And while it's laudable to think about getting this done in a very short time frame, the work is beginning to fall behind schedule a bit, and so it looks like it's going to take longer than we've anticipated to get these two changes fully in place. That's somewhat important because of a problem we encountered early this year with funding. When funding came out from Department of Human Services for developmental disability programs in the community for this year, what we saw was that there were about 11 counties whose funding was being reduced below the level that they were funded the previous year. And at the same time, we're being asked to do more work to enact change to the K plan and the workload model. So we were actually successful in going to the legislature and working with DHS to get, I think it was about 1.14 million allocated back into the system so that all counties got brought up to the level of funding that at least where they were the year before. While that didn't affect Marion County's funding very much, we were still being asked to do a lot more with an increased caseload with not a whole lot more money. But what I worry about is if we have delays, there's not a clear funding model that would direct an adequate amount of funding into the system if we don't manage to get to the workload model somewhat efficiently. So I'd like to talk a little bit about that pie chart in your handout. If you look at that page, you'll see an arrow that starts at Department of Human Services, DHS, goes across the top and then down, and an arrow going to community providers and families. Whereas it represents almost $62 million worth of direct payments that are going from the state to community providers. Before 2008, when the express system that provides these direct payments rolled out, that money was coming through the health department and was part of our budget. So if you think about what that means, that budget would be that much higher in case our direct payment system had not rolled out. Our staff still plan with the families, create an individual support plan, and authorize payments under this system. But we are freed up from the additional administrative overhead and burden of having to have multiple contracts with providers for exchange of money, multiple amendments with state DHS about every change to somebody's funding. And we're not part of the inevitable reconciliation between providers and county, and state. While there have been less successful implementations of state computer systems, Express really has been a model of electronic innovation and improvement. So this direct payment system has been a very good thing for us and for the system because it allows us to concentrate more on the work of service and the appropriate level of service, and the payments are made in a timely fashion direct from state to providers. So we would like to move anything that is of a similar nature into that direct payment system. So things that are not coming to us for our services, if we can send them through the Express, that's more efficient and appropriate. So one of the issues that we're looking at concerns payment for personal support workers in the homes. And if you look at that pie chart, you'll see a blue wedge that has about $2.2 million in it. And that has to do with the amount of money that's coming in our contract that has been going out to pay these personal support workers. Contracts for these workers are negotiated between SEIU and the state, and then the state turns around and gives us money for us to pay them under that contract. We've managed to stay out of an employment relationship with them by using a fiscal intermediary, Resource Connections of Oregon, or RCO right now. And it's actually the family that remains the employer of record for the personal support workers, using RCO as their administrative intermediary. So what we'd like to see is that 2.2 million move into the express system so that those workers can be paid directly, rather than having that money come to us and our having to touch it and have multiple contracts to push that out. The date that was set for transition was July 1st, but we just received an email last week that says that the move to the express system for personal support worker payments may take a few months to beyond July 1st to transition. So whenever that transition occurs, that $2.2 million will move out of our contracts and into the express system. If it takes a quarter, then about a quarter of that funding will remain in our contract for this coming year. Right now, it's all budgeted in there as if the move has not been made yet. And whenever that happens, we'll do a budget amendment at that time.
The budget reflects the 2.2 million actually being moved into Express. It's not included.
Oh, sorry.
In the budget, so.
Say that again,
Misspoke.
please.
I'm sorry, the 2.2 million, that blue slide actually it has not been included in our budget because of the expected date of July 1st being moved to Express and being direct paid by the state. So we've not included that money in here. And so if there's a delay, potentially what we're hearing is possibly September, what'll end up happening is about a quarter of that 2.2 million will have to be added back into our budget in a first supplement.
And that's pass-through money from DHS that you have to add because you have to account for it because you're going to handle it until
We'll have a contract with
the
these providers
Express.
for a couple of months, yes.
Okay.
So I apologize. I totally misspoke that. I had it backwards.
Okay. That's why he's here.
Yes, exactly. So the red section of that pie chart, the $5.4 million, we anticipate that will be approximately what our contract with the state will be for services that we provide for developmental disabilities. And we think that might grow some depending on when we get to the workload model because we're anticipating an increase under that. But then again, it's not clear when we will actually get that model in place and when it would affect our revenues. And so we'll wait and see when that contract amendment comes. That's not going to happen anytime in the immediate future. Okay. Anything on behavioral?
Rod, before you move on, just so that I'm clear, this chart that you provided on page 3 shows the flow of dollars of that 61,955,923. No. Actually, the DHS dollars would be that 61 plus the 2 plus the 5. And this shows how those dollars are portioned out. Some goes directly to providers, some comes down, it looks like about 7.5 million comes down. 220 is moved out to providers, some of it comes down to the health department to manage the program, of which 707 goes back to community providers.
Yes, we pay directly for services there with that amount of money.
Yes.
And the remainder of that 5.4 go to pay for our health department delivered services.
Okay. I think that, to me, you have such a complicated budget because so much of your money is passed through that comes on other people's fiscal years and other people's grant schedules, and then you have to staff portions of people in your staffing plan, a portion of which 1/10 of an FTE is used to manage that program, but if that program goes away, I mean, it's a real Byzantine kind of budget, and I'm just trying to keep my hands around it.
And we were hoping actually that the visual would
Yeah.
illustrate a little bit of that and make it, give you an anchor to kind of connect the verbiage to. It is complicated, and it, given so much being in flux in the developmental disability system right now, it's good to know at least a point in time where we are and what the assumptions underlying the budget are.
Exactly. Yes.
Chair
Commissioner
Vance,
Brentano.
Rod, so could you talk to us a little bit about the adequacy of the 5.4 million for the health department? Because I can make up a lot of work you have to do. Maybe it isn't, but selection of the people, planning, monitoring, and then even direction, is that enough?
Well, you're leaving out a few services like protective services and crisis intervention and a few things like that too that we do. I mean, there's the list of services we provide is quite long, and as a county community disability program, we are required to do some safety net services for the individuals in our care or system oversight and management like adult protective services that other providers are not required to do. Is it enough? I think, Commissioner Brentano, it really has to do with, that's one of the reasons for this desire to move to a workload model that really is based on what is the work being done and what does it cost us to do that. In the end, we may end up only getting paid 90% of what it would cost the state to do that, but we're anticipating that the reimbursement there will go up. I think it was about 10% more, if I'm remembering correctly, that the aging services system, the AAA's, area agencies on aging, received when they went from caseload to workload model. So when you take a look at this, is this sufficient to the work we're tasked with? Not really. And I think it kind of varies by county as well. So right now we have debates periodically about, well, Marion County's caseload went up, so we should get more money. Well, is that true? Did we actually do more work because of that? Or did Grant's caseload, which really went down a little bit, is the work still the same out there, and are we penalizing them by taking away money for that caseload reduction? So I'm hoping, the hope of doing all this work, and it's really heaping a lot of work on top of a system that has already been stretched for years to meet the needs of the people who require our services. It's worth doing that work if we can get to something that really is more reflective of what it costs to sustain that system.
I might be wrong on this workload. You're telling me that workload versus caseload affects the health department. My first thought was that it would affect providers who only want to take the easy ones if you got paid the same. So a little comment on that if that's way offline. And then I'm wondering about, more than just send the money, does the state provide any service or directly to providers or the individuals? So they just pass on the money, it's all health department that does the work?
It's actually a couple good questions there. I think that your comment about providers that just take people with less need and easier to work with. We do have differences in our system between counties, which generally serve people with more serious intellectual and developmental disabilities, and other providers, including brokerages, that provide less comprehensive levels of care. I think the caseload model is exactly the problem you were alluding to. If you count everybody who's enrolled with you equally, regardless of need and service level, then you really penalize folks who are serving individuals with more need and a higher level of service. And that's what the workload model is attempting to address. Does the state provide any services directly? Until recently, there were state-operated group homes, and those were Fairview closed in a series of downsizing. There were different phases, and as you obviously moved people out into the community who were most ready to move to the community and who would not need the most intensive supports or programming in the community. And so as Fairview phased down, the difficulty of placing somebody in the community and still maintaining appropriate level of community safety as well as meeting those individuals' needs became tougher and tougher. So for a group of folks, there was a system of state-operated group homes that was set up in order to provide the supports they needed to move out of Fairview. Those programs are transitioning into crisis stabilization units, and many of the folks that have been in those units since Fairview closed are moving out into other community placements currently, and the state is getting out of the business of operating the group homes. So does the state provide a direct hands-on service? Not really.
Carlson?
And just to take on that, but the state would say that they provide other services other than direct services that would be setting standards, oversight, accountability.
Extremely valuable services, and it's kind of, figuring out how that state and community partnership works, and then how we as the Community Developmental Disability Program work with other community providers to make sure that they're getting funded for the work they do and supported in terms of when somebody's need increases. We're the ones that kind of step in and either shore up resources or find a different placement for individuals. So it's an interactive system.
Right. So the original reason I raised my hand was I wanted to comment. We had a presentation about this, all of these issues that are really intertwined through the Local Government Advisory Committee to DHS, and a couple things that I just wanted to add. One is that this K plan, as I understand it, Commissioner Brentano, you were asking about, is the money sufficient? Well, it's not sufficient now, and when the additional responsibilities get added in with the K plan, it's going to be even less sufficient, and that's why they're doing, I think, the analysis at the state level on the workload model, adding in the K plan responsibilities to make sure that all of these functions are considered in terms of a reimbursement. The other piece is that the Legislative Fiscal Office, as I understand it, has been doing a survey of counties, or I guess DHS has been doing a survey that the Legislative Fiscal Office endorsed, which is a major thing. And so that survey then goes into the Ways and Means Committee. So my question, Rod, for you is, because you mentioned that they would implement the workload model, my recollection was, or my understanding was from the presentation, that folds into the 2015 session, that then that survey goes in and they review that. So are you anticipating that there's any change before the legislature actually approves the new model? And because if not, then my guess is that we really won't see any additional money this year because it will get implemented July 1 of next year.
That's also my understanding of when the issues are going to get decided. I think that the real issue is that if it extends beyond that, then the system is in real trouble in terms of the inadequacy of the current funding level being multiplied into, we no longer have a bridge to 2015. We have a cliff that we drop off, and I think that's the danger if we don't get the work done. But no, I don't expect to see a lot more money. there was some talk of pushing out some money for certain services as the additional requirements under the K plan move out, such as all the assessments that have to be done. But right now, we are our crisis services, our regional crisis team is actually assisting the brokerages in our area to complete their assessments, because that's the place where the comprehensive assessments have not been done as frequently or in as much detail in the past. And that's one of the requirements of the K plan. So I would anticipate that we'd have to get funded for that if that rolls into another year.
Just the comment that you made me think that maybe the money was going to come sooner than the next legislative session, but
It'd be nice.
you're confirming that it's likely that it won't. Thank you.
Thanks, Rod.
Okay. I'd like to talk a little bit about behavioral health right now and some of the issues that we're facing there. Those include alcohol and drug treatment services, begins on page 461, and then the other services between page 469 and 486 in your budget book. But we also have a handout page, and that is page 4 of your handout, that has 2 pie charts on it. And it's titled Marion County Health Department Community Mental Health Programs, CMHP, Local Mental Health Authority, LMHA, Funding Changes. So I'll be referring to that after a bit to illustrate some of the issues that we're grappling with. Overall, the behavioral health programs have a budget of about $46 million and last year we served about 24,000 people with over 271 client contact in these programs. I want to talk about probably the biggest change that the state health system is going through, and that is the consolidation of funding for Medicaid services with the coordinated care organizations, or CCOs. And that change is having a tremendous impact on counties and county services. So as many of you probably know, the state of Oregon has been engaged in a project for transforming Medicaid health services for the last couple of years. And the principal vehicle for this transformation is intended to be the coordinated care organizations. These organizations are responsible for managing the Medicaid benefit both for the physical health and for the behavioral health services. And the notion is by breaking down those silos in funding, that provides the opportunity and facilitates the integration of care across behavioral health and physical health, which have been siloed up till now. I do want to comment, though, that that doesn't happen just by breaking down fiscal silos. There needs to be a lot of work to really get to transformation, and I think that's what our group here in Marion and Polk counties is really starting to grapple with. The principal coordinated care organization in our area, which includes Marion and Polk counties, is the Willamette Valley Community Health. Our long-term mental health organization that has been receiving capitated payments from the state to provide mental health care in this region no longer receives those payments directly from the state. Those payments are going through the coordinated care organizations. Our arrangement currently is that the Mid-Valley Behavior Care Network, BCN, that mental health organization, receives a portion of the Willamette Valley Community Health Fund to manage the behavioral health care services. And that's ongoing in our current contract. That's probably going to evolve over time. The next contract comes up in January of 2015. But for the last year and a half, our operations have looked on the surface somewhat similar to what they had in the past. But what we have been charged with is figuring out how to integrate primary care and specialty mental health services that we provide through the health department and also a community provider panel called the Integrated Delivery System, or IDS, of folks that provide behavioral health services in our community and have done so for over almost 2 decades. One of the things that, just to give you an example of it, that we've been instrumental in trying out with primary care is to house what are called behavioral consultants or behaviorists within the primary care office. That is something that mental health is paying for currently. And the role there is not to become the long-term therapist within the clinic, but to be there to consult with the doctor, nurse practitioner, other medical staff about things they might be experiencing with a client that comes in for medical care. How much of that might be related to a behavioral health issue? If so, what kind of behavioral health interventions are appropriate? What kind of things can they do on the medical side to assist those interventions? Behaviorists also can see people for a couple of brief sessions, and if the problem requires more care than that allows, then the behaviorist is in a great position to refer individuals out to and make sure they connect with the specialty mental health services that are available for longer-term care. And we hope that going back in the other way, where somebody's transitioning back to care at the clinic, that the behaviorist will help as well. We just had a satisfaction survey of the primary care clinics that participated in this project this year, and universally they said, "This is great, don't stop." And so we're working out a funding mechanism with the coordinated care organization to basically split the funding going forward for next year is the plan right now. But we're also looking to expand that beyond the current 7 folks that we have out there. So the Behavior Care Network, BCN, is changing. It's been a organization of 5, then 4 counties, but as the other 2 counties, then Marion and Polk, have become associated with other coordinated care organizations, they have decided to resign from the BCN. So as of January, BCN is going to be an organization that is a Marion and Polk focus. So what we're looking for is actually to use that structure to take on responsibility for contracting for behavioral health services and managing provider contracts directly through the BCN. And what that does is it provides the advantage of being able to have a consistent contract and a consistent set of providers across Marion and Polk, so it doesn't matter if you live on the west side or the east side of the river. Our folks will get taken care of in the same ways, but it will provide much better integration within the mental health system so people don't have to worry about being asked, well, where do you live? As long as they are a Willamette Valley Community Health member, they'll be entitled to the same services at any of the agencies. Okay. So some of these are large changes to some of our programs, particularly the Community and Provider Services program, which has for the last couple decades managed outpatient care here on mental health outpatient care and managed the provider panel here in Marion County for Marion County residents. So transitioning that to the Behavior Care Network causes a bit of anxiety. Some of the funding that's coming to Marion County obviously would be being retained by the BCN to do that function. It's not entirely clear how those functions will be structured at the BCN. We anticipate it's likely that most of those system management functions, contract management functions will be needed at the BCN, but it's quite possible that some of those might be restructured or combined differently in terms of positions going forward. So I just wanted to mention that this is a time of considerable uncertainty and quite a bit of anxiety for some of our staff that has been doing that work admirably for quite a while now. Okay, so what difference would that make? Well, currently we've been receiving the entire allocation for outpatient services, Medicaid outpatient services from the BCN on a monthly basis. And then we have been managing that system, both providing services ourselves and also contracting with a community provider panel to provide those services. As of January, those latter contracts will move to the BCN, and we will not be managing those anymore, and we would not have the money flowing through us to manage those. Excuse me. We wouldn't have the money flowing through the health department to manage those particular provider contracts. Okay. The other issue that we're dealing with in the meantime, however, is that starting January, there was quite an influx of people who were eligible for Medicaid. A huge number of people signed up with our local coordinated care organization and are eligible for Medicaid services. The state had anticipated that there would be this change, but I think the projections of the number of eligibles were well below what actually happened. So we've been flooded with a lot of folks coming into the system with Medicaid eligibility needing services. At the same time, a number of our, let me get to that in a minute. What we've done in response is we had secured a contract exception last year, anticipating this increase in demand. And we're adding capacity not only to our existing community provider panel, the IDS, but also adding new providers to our panel on an interim basis for the remainder of this year. So we're able to do that quite quickly, and we just signed a contract with Silverton Health, for example, to add providers in the northern and eastern part of the county. So they have offices in Woodburn. Well, they even have an office in Kaiser, but not mental health there. Woodburn and Silverton, basically, will be well covered given that new contract. Ironically, this is the year that there needs to be a procurement process, a request for proposals, RFP, to kind of redo the provider panel for mental health. So that's for everybody, even the existing providers. It's time to go out and bid that system out. So we're going to be working very closely with the BCN to kind of craft an RFP that's going to work not just for the system we have now, but the system that we anticipate having after January. So if we could turn to that page in the handout with the two pie charts and look at the pie chart in the upper left-hand side there. Those are general fund or non-Medicaid, more correctly, revenues that are coming into the health department. And those are on the order of about $10.9 million if you add all those sections together. The red section represents funding that has been coming to us for some time and will likely continue, the service elements there. But I do want to point out that a number of those service elements have been changing rapidly. and probably will continue to fluctuate going forward. For example, our crisis services funded by State General Fund were cut by 50% in January, and the outpatient adult and children's services funded by these non-Medicaid funds were cut by 35% for the remainder of the biennium at the same time. And the reason that was done is that the state's calculation, based on what has happened in other communities, was that as Medicaid expands, the number of folks that don't have insurance coverage decreases. And so it's a balancing act of figuring out how quickly people are going to get covered, and that demand for services by people without coverage decreases, and how quickly the demand increases. Well, we're quite certain that the demand for services by Medicaid, newly eligible Medicaid folks has skyrocketed. But we're not sure whether the actual experience yet of increases and decreases matches the projection all that well. It appears that a number of folks in our crisis system still are coming through that don't have Medicaid coverage. And so we're working really hard to get them hooked up with coverage, especially those coming out of institutions or incarcerations. Also, it's really important to get people hooked up with that coverage because we don't have as much general fund that funds the safety net services as we used to. Okay. So as I said earlier, the Oregon Health Authority made some...
Let me interrupt you for just 1 second, because you included in that population folks that are coming out of incarceration, out of prison, and Marion County has a disproportionate share of folks being discharged into Marion County. Marion and Polka, or Marion and Multnomah, I think, are among the highest, Commissioner. So that could, I suppose, if that wasn't accounted for and you weren't planning for that and you weren't trying to coordinate, and I know there's a lot of coordination effort going on, but if that were to slip and fall, you could end up with all kinds of folks sort of falling through the cracks. And I just wanted to make sure I'm on the right track with that. You sort of went through it pretty quickly, but it's not a small issue in Marion County.
It's a huge issue here. I think that, as people get incarcerated at the jail, the notion is that we are supposed to suspend benefits and so that we can restart them quickly. We're just beginning to figure out how that's going to happen and get some clarity as to the process that's going to take in order to get that to happen. Our work with law enforcement, the courts, corrections, the DA's office has been stellar over the years. We have such a collaborative system here in Marion County. I'm not going to talk a whole lot today about the crisis outreach teams and the court teams and the other joint teams that we've put together. But it makes it really easy for us to start talking about, well, if we're going to be able to suspend and restart benefits, how do we do that and what are the implications? Mm-hmm. There's also, I think, something that's needed at the federal level about Medicaid benefits, because if insurance companies, non-Medicaid, non-federal insurance, is being required to have a benefit that continues during incarceration at the jail, why not Medicaid? And the cost of health insurance and incarceration, as you well know, Chair Vance, is quite high.
Yeah. Thank you.
Okay, so as I said earlier, there was a community reinvestment initiative that took a lot of RFPs and pushed money out into the community. And if you look at that purple wedge of that pie chart for over $2.4 million, that is the result of a very successful series of applications that Marion County had in response to those RFPs. I think we responded to 10 of them and were awarded 8 or something like that. That came at great cost, of course, and The other piece, not just how much time it took us to apply in order to get the money, but the rest of the system, there are many counties that weren't awarded funds under this initiative, or were awarded very few of the responses they turned in. There were also a lot of small counties that did not have the resources to apply for many, and some that couldn't apply for any of these initiatives. So there was a lot of money out there that got distributed on a competitive basis, which sounds good until you realize that that starts to create a very inequitable, disproportionate system. So Marion County has a lot of resources. We have mobile crisis outreach teams where we have a sheriff's deputy and one of our mental health folks riding around together. We have alternating with a Salem police department officer and one of our mental health teams. We have jail diversion funding, and we have a sort of community outreach team funding because of that. But if you look in other communities, those services are not going to be available because they were not successful in getting a response to award to their RFP. And what we're starting to build is a system that looks more like back in the late 80s and early 90s, when we actually had to do a lot of refunding the system to be more equitable so that Oregonians have an equal access to a mental health system across the state. So what's good for Marion County in this particular instance is not a good systems move, and so far our responses when we've brought that up to Oregon Health Authority have been that they really like this competitive process. So kudos to our staff for securing these really important resources for our community. It will benefit our community a lot. Worries about the overall system implications down the road. So that final wedge, the blue wedge, it's about $1.66 million, and those represent funding for residential services. The state has been working with the coordinated care organizations to try and transition that funding to the coordinated care organizations for some time now. And I think the date has slipped twice, and we don't know right now when that will be. It was supposed to roll out, I think, in January of 2014, and then July, and now it's not going to be July. So for the time being, that money is staying in our budgets, but eventually, if it does transition, about $1.66 million will move to the CCOs.
Rod, those are non-Medicaid dollars intended for residential services to eligible clients, and they would be funneled over to the CCO? Okay.
There are a number of general fund services or funding that's being discussed to move to the CCO.
Okay.
Because one of the things, it's very difficult to coordinate care if you only have part of the funding picture. At the same time, it kind of worries us a little bit because those are the things that we use to provide a safety net system within our community.
Mm-hmm. Yes, sir. Ms. Cameron.
Question. Thank you. Thanks, Rod. So just to clarify then, the blue, the 166 here is in your budget today, but may come out.
I think I got this right this time.
But if we flip the page over, the blue section, the 2.2 is not in the budget, but may have to come back in the budget because of the delay of, all right, okay.
That's correct,
Just want to make sure.
Yep. Sorry about that confusion.
Thanks, Rod.
Okay, so if we look at the pie chart in the bottom right-hand corner of that page, what you see is about $24.3 million coming from Willamette Valley Community Health through the Mid-Valley Behavior Care Network to pay for outpatient services to individuals in Marion County. So what we're looking at is all that money is currently coming to us, Marion County, right now. But the blue section is the piece of that funding that actually is passed through and goes out to the integrated delivery system community providers. So as of January, we would expect that BCN will have direct contract with those community providers, and that money will not be coming through our budget at that time. So the $14.2 million in the red represents money that goes to health department services and to some extent system management services right now. As I said, some of that contract management, provider management contracting will be moving to the BCN, so we're not exactly sure how much that will be. And that's that little piece of the red that's pulled out there a bit with some question marks. So there's a lot here that needs to be negotiated. I think that we might see the blue piece of the pie increasing, certainly that little piece of red going to contracts management through BCN starting January. Let me just stress that the amount that we have in the red is based upon what we currently project and how we're contracting services. That has not been negotiated with the BCN, so we will actually have to negotiate how much money is going to be coming to Marion County Health Department for services January on, and it may be a bit different from that amount.
And you're talking here, Rod, about the 14,228, 424.
Right.
As some of that funding shifts over to community providers and so on, it'll affect what you're doing. And that's money that funds programs that are similar to the community provider programs, but as part of the safety net. Am I confabulating stuff, or?
I think they're similar. Some of them are higher end services. For example, we provide a program called New Solutions, which is care coordination and wraparound services that does fidelity evidence-based practice. And basically it's a fairly expensive service to provide. The county provides that rather than having contracted that out. I think part of that is kind of determining eligibility and best placement, and kind of as the resource of last resort. Counties are always kind of looking for, well, we're going to figure out what to do to help this family, no matter what it takes. So we're going to get on upstream of that and make sure that we have a part in that discussion and the resources to help direct people to
When you're
service.
talking about negotiating with the BCN and WVCH, that's what you're talking about, is being sure to preserve some of that funding for those essential programs that probably won't be provided. I mean, if this went away, those things couldn't be done because community providers aren't set up the way the health department is. Am I following?
They're not currently set up that way. Certainly a future could look that way. I think that counties have certain responsibilities, especially around safety net services, where you have to combine these Medicaid dollars with some of these general fund dollars and even the investments the county puts into mental health in order to make sure things work. No other county really has the kind of interface of mental health and forensics and courts and corrections that we do here.
Well, and that's a legacy of the BCN and the work, the inter-county work that was done, and sort of how you all got the other mental health leadership in the former BCN counties, how that all came about, really understanding the need and understanding the community in a broader scale and what parts needed to be done by who and when and how. Am I?
Yes.
Okay.
Mr. Chair, could I just
Yes, Commissioner
tag on to that just briefly? I think it's important to emphasize or to reemphasize that the Medicaid funds are used for Medicaid-eligible people, but that you do have to combine, because the Medicaid dollars are much larger than the general fund dollars that come for people who aren't covered with Medicaid, in order to create a facility like the Psychiatric Crisis Center, for example, that provides 24/7 crisis services. We couldn't do it simply with the general fund dollars. That resource would fall apart. But when you use the term safety net, I think sometimes people think of the safety net as those who aren't covered by Medicaid. So we want to make sure that we clarify that the Medicaid dollars are used for Medicaid-eligible people. We're not allowed to use them for people who are not.
Yes. I think Rod's point about the essential services,
Right.
yeah, I mixed the two up. Yeah, thank you. Thank you. Okay.
Okay, a few concluding comments. I've given a bit short shrift to public health this year. There has not been quite the turmoil in that area. There are some black clouds on the horizon. We have had some funding cuts. We are kind of in discussions or arguing with State Public Health Division about some of our funding issues going forward. There's always a debate about how much money goes to state services and how much goes to local health departments. I think I want to highlight a trend that's going on in public health, not just in Marion County, not just in Oregon, but kind of nationally. Public health has seen a decrease in the number of people coming to health departments for clinical services. And I think if you think about the rise in the access of immunizations at your local drugstore, or you can get a flu shot if you go when you go shopping for groceries, and insurance companies more ready to pay for preventive services like that. Fewer people are coming to get their immunizations at the health department. The other thing I want to mention is the state task force on the future of public health that was originally kind of touted as a regionalization task force. I think it's gotten much more general and much more, it's in the territory that could be quite helpful for the overall public health system in Oregon. It's not specifically focused on regionalization. I think there's still discussion on that point, which would be a big change if that were to occur. I think those debates and conversations with the task force are set to wind up later this summer, and if anybody has a chance to participate in any of the community meetings, I'd encourage you to do so. And finally, as Mr. Latimer mentioned, we're looking forward to having some improvement made at our Center Street building in terms of making lighting, air conditioning, and heating work better. And we're even going to be replacing all those beautiful single pane windows that leak heat or absorb heat depending on the season so well. And I think that those improvements would certainly make Center Street a much more pleasant place to work. So thank you. Any questions?
Comments, questions?
Just one comment on public health, and I appreciate the presentation and recognize that public health wasn't as controversial, although there certainly are things that are controversial in this future public health task force. But we want to make sure that we acknowledge the accreditation that happened this year, and that was the first in the state of Oregon, and 9 in the nation, or how many in the nation? Anyway, I might be getting my numbers wrong, but one of the
in the 20s now. Yeah.
Pioneers in the nation of getting accredited. It was a whole lot of work on the part of health department staff, and they should be very proud of that. So want to acknowledge their work.
It was a cool honor.
Thank you, Commissioner, because if you didn't, I was going to say the same thing, because it was a lot of work and it is a milestone. We talked the other day, when we started yesterday, about awards that various departments have gotten, and that really is a gold star for your staff, especially the folks that are really focused on public health. And yeah, congratulations. Mr. Cameron.
Thank you, Mr. Chair. And Rod, I just really appreciate your comment about even though with the state, and we were talking about this yesterday, with what the state's doing with these funds and then actually making people apply for grants, I appreciate your vision of how it affects the whole state. And it'll be interesting, the challenges down the road, as you mentioned, when other places are suffering, what's going to happen when we have to deal with that. So thanks for your vision of the whole state, not just where we're at right here. Appreciate it.
Questions? Yes, sir.
I just had one question. Well, first of all, thank you for your fine work. I'm a layman in all this, and I really, it's a lot that you're dealing with, and I appreciate it. But in your remarks, you mentioned the Medicaid, there was a goal of X that they thought would sign up, let's say, apply, but the reality was like way up here versus what they thought. And I'm wondering, is that just our county or is that statewide? And why was there such a huge disparity? At least that's the way I interpreted your comments is, I can understand it not being exact, that's reasonable, but if it's way different, what is your take on the reason for that?
Well, I think it is not just Marion County, although I think the uptake of Medicaid eligibility does differ a little bit depending on region of the state. I think if I'm remembering the numbers, and Commissioner Carlson, you might help me out there, we ended up with 60,000 new,
From 60 to 90.
40 to 60?
40 to, yeah, it was,
Yeah, I'm looking at Marion and Polk together, is what I'm,
yeah, about 30,000 here.
but I think the projection was, what, 11 or something like
Yeah.
that? It was, so it was more than double.
So it's more than double in terms of what we were led to believe. Now that won't continue. It'll level out a bit. But really, that was a huge number of people that became eligible for Medicaid and got signed up. And so, the health department and other organizations around the community actually have been very active in trying to sign people up because it's important for people to have health care coverage so that they can get access to the array of services that Medicaid provides. I think that why we missed it, what I remember is when those of you who might remember Oregon Health Plan Standard, which was early on in the Oregon Health Plan, they added a standard population which did not become eligible because of disability, but became eligible because of income. And so all of a sudden we experienced a huge surge in folks signing up, and what it reflects is pent-up demand. There's a lot of people that have not been able to get adequate medical care in our communities over time. I think mental health gets slammed pretty hard with that kind of a pent-up demand. But if you want to see pent-up demand, visit a dental clinic. That's the kind of care that people put off the most when they don't have the insurance to cover it. And boy, that has really skyrocketed. So I think it's partly that, and partly it was because we did a good job of getting people out there to assist people in signing up for Medicaid.
I think that's it. Thank you, sir.
Thank you.
Oh, we're actually about 5 minutes behind, and we're scheduled here for a break. Do you want to take about 10 minutes, phone calls and coffee and so on? So we will be in recess until 10:15. Okay, this is the June 4th meeting, Marion County Budget Committee. We will come back from recess. And next item on the agenda is Transportation Natural Resources, beginning with Public Works, Mr. Haley. And Commissioner Brentano told me you are now officially the director. Congratulations. I didn't realize that as you came in. Good to see you.
Yes,
Thank you.
Mr. Chair. And yes, and thanks to the committee. I am Alan Haley, Director of Public Works, recently appointed. With me is Dennis Mansfield, my managerial accountant, and my younger memory. So we'll move through with this. I'll be going through our programs briefly with then our budget changes and the legislative changes. And then I'd like to focus more on looking forward. I believe we are kind of heading in a good direction, but one that I think will have some future budget impacts. And then I'll have our county engineer, Cindy Schmidt, talk a little bit about this year's CIP and looking ahead to a couple of projects. I'll also stop several times for questions, but feel free to stop and ask a question anytime you like to. Our budget starts on page 535. Public Works is made up of 5 divisions: our administration, building and planning, engineering, as well as environmental service and operations. There are 13 programs inside 7 funds, and 7 of those programs are inside the 130 fund, or the road fund, as it's called. This year's budget is $93 million. That's down 1.7% from $94.6 million last year. And our FTEs are at 188.4, up 1.8 from last year. That's what the chart says even. So our administration program, the budget is $19.8 million. 16 million of that is our ending fund balance for the 130 fund. We cover our reception and dispatch areas, our accounting, including our contracts management piece, overall correspondence, records management, staff support. We also support 5 service districts. We do our public works facilities maintenance and services, our customer service advisory team, and we oversee the cable franchises, at this point of which all 3 of them are in renewal. Our engineering program has a budget of $13.5 million. Covers our engineering, design, and capital projects, which is a budget of that section is $9 million. The major function here is really interagency and project coordination. They do our annual overlay program for Kaiser and Marion County. They do our annual slurry seal program. They also do our designing and contracting for all of our transportation capital improvement projects. Construction administration, which includes field inspection as well as contract closeout. They do assist us with also our flood damage assessments and repairs when necessary. They do our cost estimates for federal highway and FEMA reimbursement. Of late, we've been doing a little bit more slide repair and road stabilization projects than we'd like, mostly notably up the North Fork. They do our hydraulic data collection and modeling and our right-of-way purchasing for our projects. Our traffic and transportation planning folks, they determine what our signing and striping needs are throughout our public roads. They handle our traffic signal design and maintenance functions, our roadway safety issues, which are vision hazards, traffic control needs, those kinds of things. Our long-range transportation planning and project prioritization. They also do our grant requests and seek funding from other outside sources. The grant request in this case is usually in the form of some sort of federal aid dollars, which we've been getting for some projects. They handle our removal and other property agreements. Our land development folks and permits, they handle our transportation SDCs. They review and support all of our planning efforts. We review development plans for drainage, erosion control, traffic issues, and they issue permits for trucking, driveways, work in the right-of-way, major construction, and utility permits. Our operations division under Don Newell, their budget is $9.6 million. They maintain 926 miles of paved and 193 miles of gravel roads. They also maintain our 145 bridges. They do our annual chip seal program, which this year is 29 miles. They also handle our crack sealing program. They do our drainage and vegetation services, overall signage, signs and pavement marking, and again, the bridge maintenance functions, and our winter operations. It's for our storm and emergency response and snow and ice control. Our shops budget, or program, which is another piece that's under the administration. The budget is $4.3 million, and we really have that heavily focused on modernizing the heavy-duty fleet to improve our productivity and reduce our downtime, and then, of course, maintain our 300-odd trucks, trailers, and other pieces of equipment